Welcome to Board Pearls. This is episode 1 of 5 of the Colonoscopy Practice and Quality chapter in the Endoscopic Procedures module. In this episode, we cover CRC screening, bowel preparation, and the detection metrics that define colonoscopy quality. USPSTF age 45 for average risk screening with the modality menu, split dose preparation with Boston Bowel Preparation Scale adequacy, cecal intubation rates, and the adenoma detection rate that is the strongest predictor of interval cancer, together with sessile serrated lesion detection rate and withdrawal time. Colorectal cancer is the disease screening was designed for. It has a long, recognizable precursor lesion in the adenoma and the sessile serrated lesion, and it has a survivable early stage if you catch the cancer before nodal spread. Every other piece of the screening apparatus follows from those two facts. The modality menu is built to give every patient a route in. The quality metrics are built to make sure the route actually delivers the prevention the interval assumes. The starting age changed in 2021. The U.S. Preventive Services Task Force dropped the age of average risk screening from 50 to 45. The driver was rising early onset colorectal cancer in adults under 50, with the strongest signal in the distal colon and rectum. The American Cancer Society made the same change in 2018. Screening runs routinely through age 75, individualized between 76 and 85, and is generally not offered after 85. The reason the upper bound exists is that the lead time required to derive any benefit from screening exceeds the residual life expectancy. You cannot prevent a cancer that will not have time to kill you. The high-risk populations enter on different protocols, and the principle to hold is that the start age and the interval both shift earlier and shorter when underlying risk is higher. Lynch syndrome starts colonoscopy at age 20 to 25, or 2 to 5 years before the youngest affected relative every 1 to 2 years. Familial adenomatous polyposis starts annual flexible sigmoidoscopy at age 10 to 12, transitioning to colonoscopy once polyps appear. Inflammatory bowel disease begins dysplasia surveillance 8 years after disease onset, or immediately at primary sclerosing cholangitis diagnosis. A first-degree relative with colorectal cancer or advanced adenoma shifts to start to age 40 or 10 years before the youngest case, with 5-year intervals. The syndrome-specific deep dive lives in the hereditary syndromes chapter. For everyone else, the modality menu is the operational decision tree. Colonoscopy every 10 years is the cornerstone because it both detects and removes the precursor in a single procedure, with sensitivity for advanced adenoma approaching 95% in well-prepped patients with high-quality endoscopists. The rest of this chapter is about what makes that 95% real rather than nominal. FIT every year is the mainstay non-invasive test. It is an antibody assay for human hemoglobin in stool, with cancer sensitivity in the 70 to 80% range and specificity above 95%. Sensitivity for advanced adenoma is under 30%, which is why the interval is annual. The repetition is how the program accumulates cancer detection over time. Multi-target stool DNA testing, marketed as Cologuard, every 3 years adds methylated NDRG4 and BMP3 and mutant CARAS to a FIT component. Cancer sensitivity rises to roughly 92% and advanced adenoma sensitivity to about 42%, but specificity drops to around 87%. That lower specificity means a meaningful false positive rate, which matters because every positive non-invasive test commits the patient to colonoscopy. CT colonography every 5 years offers anatomic visualization without sedation. It still requires the same bowel preparation as colonoscopy, exposes the patient to radiation, and generates extracolonic findings that send 5 to 15% of patients to additional imaging. Flexible sigmoidoscopy every 5 years, or every 10 years paired with annual FIT covers only the distal colon. It is now rarely used because right-sided lesions, including the sessile serrated lesions that drive a substantial fraction of interval cancer, are out of its reach. SHIELD, the Guardant blood-based methylation cell-free DNA test, was FDA approved in 2024 with cancer sensitivity around 83%, but only 13% for advanced precancerous lesions. That low precursor sensitivity is why SHIELD is positioned for patients who decline other modalities, not as a replacement for them. The principle that holds the whole menu together is one sentence. Any positive non-invasive test is an indication for diagnostic colonoscopy. A positive FIT a positive multi-target stool DNA, an abnormal CT colonography, a positive shield. The dominant clinical failure mode in vignettes is the patient who declines colonoscopy as the primary screen, then declines colonoscopy after a positive stool or blood test, and ends up with a delayed cancer. Shared decision-making at the front end has to include the explicit commitment to colonoscopy if the non-invasive test is abnormal. Repeating the stool test, switching modalities, or deferring is not a path back to safety. That sets up the next problem. A screening colonoscopy is only as good as the conditions under which it is performed. Preparation adequacy is the foundation on which every subsequent quality metric rests, because inadequate preparation roughly doubles polyp miss rates regardless of detection technique. You cannot wash a cancer out of view and find it later by being a careful endoscopist. The preparation quality, the cecal intubation rate, and the withdrawal time interlock as the three operational pillars that determine whether a screening colonoscopy delivers what the interval assumes. Split-dose preparation is superior to single-dose evening preparation for both overall adequacy and right colon visualization. The second dose is finished 4 to 8 hours before the procedure. The mechanism behind that timing is gastric emptying and small bowel transit. The second dose completes its effect within hours of the procedure. The right colon is then being washed by fresh effluent at the moment of inspection, rather than accumulating mucus, small bowel content, and enterocolic secretions overnight. Single-dose evening-only preparation lets the right colon, the segment most distant from the rectal exit, accumulate the most residue. The same physiology defines the timing window: early enough that the second dose reaches the right colon, late enough that the colon is still empty at scope insertion. The most important determinant of preparation quality is that interval between the end of the prep and the start of the procedure. The agent menu is broad, and the choices stack a safety constraint on top of efficacy. PEG electrolyte solution at the 4-liter standard volume is the standard and is non-fermentable, which matters whenever therapeutic intervention is anticipated. Low-volume PEG with ascorbate reduces volume and improves palatability with non-inferior efficacy in carefully timed split regimens. Sulfate-based oral solutions and sodium picosulfate plus magnesium oxide and citric acid combinations are alternatives for patients who cannot tolerate the larger PEG volume. Hyperosmolar mannitol preparations, used historically in some regions, are avoided when electrocautery polypectomy is anticipated. Colonic bacterial fermentation of mannitol produces hydrogen gas, and hydrogen gas in the colonic lumen during electrocautery is an explosion risk. PEG electrolyte is non-fermentable, which is why it remains the standard when polypectomy is on the table. Sodium phosphate preparations are largely abandoned because of acute phosphate nephropathy risk, particularly in older patients and those with renal impairment, hypertension, or diuretic or ACE inhibitor exposure. Adequacy is measured by the Boston Bowel Preparation Scale. Each of 3 colonic segments, the right, the transverse, and the left, is scored on a 0 to 3 scale after washing, with total scores from 0 to 9. Adequate preparation requires a total at or above 6, with no individual segment below 2. The segment-specific minimum matters because a focal score of 0 or 1 in any segment renders that segment uninspected, even when the total looks acceptable. A single unprepared segment can hide the cancer the procedure was designed to find. A patient with inadequate preparation is brought back within 1 year, often within 3 to 12 months depending on indication and prior findings, rather than continuing the standard surveillance interval. The reason is that the missed lesion risk during inadequate preparation cannot be reasonably quantified, and the original surveillance interval was calibrated to an adequately prepared exam. Cecal intubation rate is targeted at 95% or higher for screening colonoscopy, with photodocumentation of the appendiceal orifice and the ileocecal valve as the minimum proof of cecal landing. The principle behind the target is that lesions in the cecum and right colon are the most likely to drive interval cancer, and a colonoscopy that does not reach the cecum systematically misses that region. Falling short of 95% is a quality problem, not a procedural footnote. Withdrawal time is the duration of mucosal inspection from cecum to anus during the withdrawal phase, which is when polyp detection actually occurs. The minimum is 6 minutes for diagnostic colonoscopy and 8 to 9 minutes for screening colonoscopy in patients with no findings. The benefit of more time plateaus around 9 to 12 minutes. Beyond that, additional time does not add detection but does add sedation exposure and procedural duration. Active inspection time is what counts. Time spent resecting polyps is excluded from the withdrawal time metric because the metric is about how long the mucosa is actually being looked at. Those three pillars set up the question that defines this episode. If preparation is adequate, the cecum is reached, and the withdrawal time is sufficient, does the endoscopist actually find what is there? That question is answered by the detection metrics. Adenoma detection rate is the single most validated quality metric in colonoscopy, and the reason is that its association with downstream interval cancer is robust across populations. Large cohort data showed that each 1% absolute increase in the detection rate was associated with roughly a 3% decrease in interval cancer risk and a somewhat larger decrease in fatal interval cancer. And a national colonoscopy registry showed that endoscopists with the lowest detection rates had markedly higher interval cancer than those meeting benchmark by roughly an order of magnitude. The mechanism behind the association is straightforward. Endoscopists who find more adenomas during screening remove more precancerous lesions, which prevents future cancer, and they identify more pre-existing cancers, which prevents missed late-stage disease. The metric is a proxy for careful inspection, and careful inspection is what makes the screening interval honest. ADR is defined as the proportion of screening colonoscopies in which the endoscopist identifies at least one adenoma. Historical sex-stratified benchmarks were 30% for men over 50 and 20% for women over 50, reflecting underlying adenoma prevalence differences, with a combined target of 25% for screening overall. Current quality reporting frameworks are converging on a unified benchmark of roughly 30 to 35% in mixed screening populations, and the benchmark continues to drift upward as endoscopist performance improves nationally. A practical implication is that an ADR of 24% in a modern screening-predominant practice is a performance problem, even though it would have met the historical combined target. Sessile serrated lesion detection rate is a complementary metric, not a redundant one. The serrated pathway accounts for 15 to 30% of colorectal cancers, and sessile serrated lesions are missed even by endoscopists with high conventional ADR. The reasons for the miss live in the lesions themselves. Sessile serrated lesions are flat or only slightly elevated. They are predominantly right-sided. They are often mucus-capped, and the mucus cap is sometimes the most visible feature. The lesion edge can be visible only after deliberate mucosal washing. An endoscopist with high ADR but low SSLDR is preventing conventional CIM pathway cancers while missing CIMP pathway interval cancers. The minimum acceptable SSLDR is approximately 6 to 7%, with aspirational rates approaching 20% depending on case mix. There is real pathology-driven inter-observer variability in calling serrated lesions. The histologic discriminator from hyperplastic polyp is basal crypt distortion in the sessile serrated lesion versus straight-keeled crypts in the hyperplastic polyp, and that call is subjective. The practical clinical rule that comes out of that variability is that any proximal hyperplastic polyp 10 millimeters or larger is treated as a sessile serrated lesion for surveillance purposes. The detection metrics also feed back into withdrawal time. Shortening withdrawal time predictably lowers ADR, which is why withdrawal time is the most directly actionable lever an endoscopist with a low ADR can pull. Pulling the scope back faster will not find more lesions. The 6-minute diagnostic minimum and the 8 to 9-minute screening minimum reflect the time required for full mucosal inspection. The detection benefit plateau at 9 to 12 minutes is the point at which additional time stops paying for itself. Detection improvement technologies layer onto careful technique through complementary mechanisms. Computer-aided detection systems use real-time AI to highlight potential polyps on the procedural monitor, and randomized trials show roughly 10% ADR improvement. The mechanism is that the AI reduces the inattentional blindness that affects even experienced endoscopists during long procedures. It flags lesions in real time before the endoscopist's eye has registered them, prompting closer inspection. Mucosal exposure devices, with endocuff vision the most studied, attach to the colonoscope tip and mechanically flatten haustral folds during withdrawal. Randomized trials show approximately 7% ADR improvement with the largest effect on right colon flat lesions, which are the ones most likely to drive interval cancer. High-definition colonoscopes and chromoendoscopy, whether dye spray or virtual chromoendoscopy through narrowband imaging, add modest detection benefit on top of careful technique. None of these technologies substitute for the technique itself. They reduce the gap between an attentive look and what an attentive look would have found anyway. The way of thinking the episode lands on is that screening colonoscopy is a chain of dependencies, and the chain is only as strong as its weakest link. The age at which screening starts is set by where the population-level cancer risk crosses the threshold for benefit, which is now 45 for average risk. The modality is chosen with the explicit commitment that a positive non-invasive test is an indication for colonoscopy. The preparation is split dose because gastric and small bowel physiology will only deliver a clean right colon if the second dose lands hours before inspection. The procedure is judged adequate by Boston Bowel Preparation Scale criteria that protect each segment individually, not just the total. The cecum has to be reached and documented because the right colon is where interval cancers most often originate. The withdrawal has to be long enough for inspection to actually occur. And the detection metric that ties all of this to downstream cancer is the adenoma detection rate, with sessile serrated lesion detection rate as its complement on the serrated pathway. Each link in the chain has a mechanistic reason for being where it is. A stem that pulls on any one link is testing whether you can reconstruct the rest from the principle that holds them all together. The next episode picks up where this one ends. Once a lesion is found, the question becomes what to do with it, and that turns on what kind of lesion it is. Episode 2 covers polyp recognition and morphology through the Paris, NICE, JNET, and Kudo classifications, then resection technique selection by polyp size and morphology. The episode after that takes the malignant polyp, its management by Haggett and Kikuchi levels, and the 2020 U.S. Multi-Society Task Force post-polypectomy surveillance intervals. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 5 of chapter 30, and I'll see you in the next one.